Hi everyone, welcome back to my channel. In this video, we are going to talk about the specimens in OBGY, which can come as your OSCE station. So let's start. Introduction. It is essential for medical students to be familiar with the pathology of various disease conditions in obstetrics and gynecology, as it forms the basis for understanding of the clinical signs and symptoms and treatment of disease conditions. It's not always possible for students to be present during all surgeries and deliveries to see all the pathological lesions. A collection of pathological specimens will serve as an alternative way to study the pathology. So this chapter deals with the common pathological specimens that are discussed during the practical Viva examination in obstetrics and gynecology. So this is good for your Viva. The usual pattern for description of a pathological specimen includes first you have to give a brief description of the gross features of the specimen. Then you have to say the diagnosis or the differential diagnosis. So even if the diagnosis is evident on inspection, you have to describe the specimen first in order to justify the diagnosis. You can't just directly tell the diagnosis. So description of a specimen, it includes the following: identification of the organ, description of the pathology as seen on naked eye, examination. Gross appearance of specimens. Do's. While describing a specimen, the main organ that is visualized must be first described. Other related organs along with the main organ present in the specimen must also be described. The gross pathology in the specimen is then described. The answer may be concluded by giving a probable diagnosis or differential diagnosis. Don'ts. When a specimen is given, do not directly jump to the diagnosis, even if the diagnosis is obvious. For example, in a specimen of fibroid uterus, do not start by saying this is a specimen of fibroid uterus. Instead, first describe the organ, that is the uterus, then describe the presence of growth in the myometrium, and then describe that it is a specimen of fibroid uterus. So cut specimen. In case of a cut specimen or cut section of a specimen, the layers of specimen organs should be described. For example, in a specimen of a cut section of uterus, various layers such as serosa, myometrium, endometrium, and the endometrial cavity are all to be described. Diagnosis. The most probable diagnosis or differential diagnosis must be mentioned. So specimens, let's start with the specimens. The first specimen over here is this one. So this is a specimen of fetus with the following features. Absence of vault of skull and exposed brain tissue with protruding eyeballs. Okay. Chance of presence of associated malformation. The fetal bag should be inspected to detect spinal cord anomalies like spina bifida, meningocele, and myelocele. So your examiner can ask you, how is the diagnosis of anencephaly confirmed? You would say, ultrasound findings, absence of cranial vault can be noted as early as 10 weeks of gestation. The biparietal diameter cannot be measured. Failure to identify the fetal skull bones and brain tissue above orbits. Maternal serum alpha fetoprotein, MSAFP. Increased levels of alpha fetoprotein in amniotic fluid and or maternal serum at 13 to 15 weeks of gestation. Clinical examination, abdomen examination. There is difficulty in palpation of the fetal head in later half of the pregnancy. Pelvic examination, the fetal skull bones and sutures are not felt in per-vaginal examination in cephalic presentation. So this is how it looks. Diagnosis क्या है? Specimen of fetus with anencephaly. Second question your examiner can ask, what complications are associated with anencephaly during pregnancy? There is an increased risk of polyhydramnios, malpresentations, and tendency for post-maturity. Polyhydramnios because the fetus is not swallowing the amniotic fluid. How should a case of anencephaly be managed? If diagnosis of anencephaly is made, pregnancy is terminated after counseling the parents as it is incompatible with the extrauterine life. What are the common neural tube defects encountered in clinical practice? There can be anencephaly, meningocele, spina bifida. What are the steps to prevent neural tube defects? Folic acid supplementation 4 mg daily started 1 month prior to conception helps in prevention of the occurrence of neural tube defects. Okay, 4 mg daily. This is something they ask all the time. Folic acid ka. Specimen 2. This is the second specimen. Gross appearance is a hysterectomy specimen of a gravid uterus. Diagnosis, cut section of specimen of gravid uterus probably removed due to uncontrolled postpartum hemorrhage or uterine rupture. Viva corner. So, what can your examiner ask you? What are the reasons for performing hysterectomy in a pregnant woman? If there's atonic PPH, traumatic PPH, ruptured uterus, morbidly adherent placenta such as placenta accreta, increta, percreta. How do you define PPH? Very important question, very commonly asked. WHO definition: the amount of blood loss of 500 ml or more following vaginal delivery, or blood loss of 1000 ml or more following a cesarean section is defined as PPH. So that was a WHO definition. What is the clinical definition? Any amount of bleeding from or into the genital tract following birth of the baby or up to the end of the puerperium, which adversely affects the general condition of the mother, as evidenced by rise in pulse rate or fall in PP, it is termed as PPH. What are the important causes of PPH? Remember the 4 T's: tone, trauma, tissue, thrombin. Tone, trauma, tissue, thrombin. Tone is atonic uterus, trauma is genital tract trauma, tissue is retained products of conception like placenta and all, thrombin, coagulopathy. The most common cause of PPH is atonic uterus. What are the risk factors of PPH? Grand multipara, uterine overdistension, because of multiple pregnancy, polyhydramnios, anemia, antepartum hemorrhage, prolonged labor, morbidly adherent placenta, trauma to the genital tract. What are the medical measures available to control atonic PPH? Medical management options available for atonic PPH are oxytocin 20 units in 500 ml normal saline, started intravenously at the rate of 60 drops per minute. Injection methogen 0.2 mg IV. Injection carboprost, which is a PGF2 alpha, 250 microgram intramuscularly, can be repeated at intervals of more than 15 minutes up to a maximum of 8 doses. Misoprostol PGE 1000 microgram placed per rectally. Intramyometrial injection of carboprost 250 microgram. What are the surgical measures to control PPH? Explore the uterus under general anesthesia. Repair any genital tract injuries in case of traumatic PPH. Uterine tamponade with a hydrostatic balloon catheter like a Sengstaken Blakemore esophageal catheter. This is there in surgery also. Balloon is inflated with 200 to 500 ml saline and is kept in situ for 4 to 6 hours to secure hemostasis. Hemostatic compression sutures. Hemostatic suture techniques are effective in controlling severe PPH. These suture techniques are B-length sutures, modified B-length sutures, and multiple Cho sutures. Then you can do uterine devascularization procedures like bilateral ligation of uterine vessels and uterovarian vessels. Bilateral internal iliac artery ligation, which is an effective method to control PPH. Uterine artery embolization, it requires the equipment and interventional radiologist to perform this procedure. Yeah. Hysterectomy is the final step if the patient is not responding to any of the above mentioned methods. What are the components of active management of third stage of labor, AMTSL? So AMTSL for prevention of PPH is practiced universally for all deliveries, and it has 3 components. Administration of uterotonics, preferably oxytocin 10 units IV or IM, immediately following delivery of baby, controlled contraction to deliver the placenta, and massage of the uterus. What are the common causes of ruptured uterus? So rupture of uterine scar, obstructed labor, injudicious use of oxytocin. You just keep using oxytocin on and on and on. It can cause ruptured uterus. How do you manage a case of ruptured uterus? Resuscitation, you have to do resuscitation, and emergency laparotomy are done. Repair of the uterus may be done in selected cases. Tubal ligation is recommended along with the procedure. If repair is not possible, then hysterectomy is done. So now let's look at the next specimen. This is the next specimen. Okay. Gross appearance, the specimen is a tube-like structure which is identified as a fallopian tube by the femoral end. Adjacent organs like uterus or ovary cannot be identified. This implies a salpingectomy was done. The tube appears distended. Okay, so it is distended with a tissue protruding out, probably gestational sac. Diagnosis: a ruptured ectopic pregnancy for which salpingectomy was done. Viva corner. What can the examiner ask you? Possible Viva questions. What are the risk factors for ectopic pregnancy? History of pelvic inflammatory disease, previous tubal surgeries, history of tubal ligation and tubal reconstructive surgery, previous ectopic pregnancy, assisted reproductive techniques, especially if tubes are damaged, intrauterine contraceptive device IUCD usage. If there's failure of IUCD and pregnancy occurs, it's more likely to be an ectopic pregnancy. What is the clinical presentation in ectopic pregnancy? Clinical presentation, classic triad of amenorrhea, abdominal pain, and vaginal bleeding is present. Positive urine pregnancy test is present. Signs, pallor, tachycardia, hypertension, and shock are present. On bimanual examination, the uterus appears bulky and fornical tenderness or cervical motion tenderness may be present. Ultrasonography USG may show free fluid in the pouch of Douglas, suggestive of hemoperitoneum. Clinical presentation in unruptured ectopic pregnancy, urine pregnancy test is positive, and adnexal mass with associated tenderness may be present on bimanual examination. Transvaginal sonography TVS reveals an adnexal mass with empty uterine cavity. So, what is the management of a ruptured tubal ectopic pregnancy? Resuscitation and laparotomy are done. Total or partial salpingectomy on the side of the ruptured ectopic pregnancy is done. Blood transfusion is often needed. What are the management options for unruptured tubal pregnancy? Conservative management, medical or surgical, definitive management, salpingectomy. So what is conservative medical management? The drug commonly used is methotrexate. Other drugs that can be used are potassium chloride, prostaglandin, hyperosmolar glucose, and actinomycin. Prerequisites for medical therapy: hemodynamically stable patient, serum beta human chorionic gonadotropin HCG level less than 5000 IU per liter, absent fetal cardiac activity, no intra-abdominal hemorrhage. Single dose regimen or variable dose, multiple dose regimen of methotrexate can be given. Single dose regimen, a single dose of methotrexate 50 mg per meter square, intramuscular injection is given. Monitor with serum beta HCG on D4 and D7. When there's a decline in beta HCG between D4 and D7, when the decline in beta HCG between D4 and D7 is more than 15%, then serum beta HCG is followed up weekly. When the decline is less than 15%, and its second dose of methotrexate 50 mg per meter square is given on day 7 and followed up. Variable dose regimen: methotrexate 1 mg per kg intramuscular on day 1, 3, 5, 7 and leucovorin 0.1 mg per kg intramuscular on day 2, 4, 6 and 8 are 1, 3, 5, 7 and 2, 4, 6, 8 nice are administered. Monitor with serum beta HCG weekly. Conservative surgical management: salpingostomy, longitudinal incision on the anti-mesenteric border of the fallopian tube over the site of ectopic pregnancy. Products of conception are removed. The incision site is kept open that heals by secondary intention. Salpingotomy procedure is the same like that of salpingostomy, but the incision eye is closed. So that was a stoma, right? Like stomy, and this was just otomy. Okay. So what are the possible questions they can ask? No, wait. I'm sorry. So let's move on to the next specimen. This is the next specimen. Very commonly asked. Very commonly asked. Gross appearance. The specimen shows a cluster of translucent vesicles or grape-like structures. What is the diagnosis? The diagnosis is probably Hydatidiform mole. What are the types of molar pregnancy? Molar pregnancy is of two types: partial and complete mole. On gross inspection, complete mole has no fetal or placental tissue, and partial mole may have fetal or placental tissue. How is gestational trophoblastic disease classified? So you have benign GTD and malignant GTD. Benign would be complete hydatidiform mole and partial hydatidiform mole. And malignant would be invasive mole, choriocarcinoma, placental site trophoblastic tumor. How will you terminate a molar pregnancy? A molar pregnancy is terminated by suction evacuation. Now let's move on to the next specimen. Okay. ठीक है. Gross appearance specimen of fetus is shown. Okay, it's not really clear, but ठीक है. The discoid shaped structure attached to it. One side of the discoid mass is brown in color, with a rugged look, having multiple cotyledons on the maternal side. You can see, okay, right, these are the cotyledons. The other side is smooth and covered by thin membranes, this side. And a cord-like structure is attached near the center, this one, fetal side. So the specimen is that of a fetus with its placenta. What are the possible Viva questions they can ask? What are the functions of placenta? transfer of nutrients to the fetus and waste products from the fetus across the placenta, endocrine function, synthesis of hormones and enzymes necessary to maintain pregnancy, and barrier function and immunological function. These 4 functions you must say it in the exam. What are the various placental abnormalities? Placenta substantiata, one or more small lobes of placenta placed at varying distances from the main placenta. So there are small lobes of placenta at different distances. So a leash of vessels traverses through the membranes connecting the main placenta to the small lobe. In case of absence of communicating blood vessels, it is termed placenta spuria. Significance: it is a substantiate lobe if the substantiate lobe is retained following delivery of placenta. It can lead to PPH, obviously, subinvolution of uterus and uterine sepsis. Battledore placenta. The cord is attached to the margin of placenta. Battledore is margin. Okay. Circumvallate placenta. The fetal surface is divided into central depressed zones surrounded by a thickened white ring situated at varying distance from the margin of placenta. The ring is composed of a double fold of amnion and chorion. Vessels radiate from the site of cord insertion up to the margin of the ring and then disappear from the view. Velamentous placenta. The cord is attached to the membranes. The branching vessels traverse the membranes for a varying distance before reaching the placenta. Significance: if the leash of blood vessels traverses the membranes overlying the internal os in front of the presenting part, it is called vasa previa. A rupture of the membrane involving the overlying fetal vessels leads to fetal bleeding, resulting in fetal exsanguination and death. Refer to the following figure. This is battledore placenta because margin pe hai. Then we have velamentous, insertion of cord, substantiate lobe, small multiple lobes here and there. Then you have circumvallate placenta. Okay. Now have a look at the next specimens, the 6th specimen. You can see, yeah, right. It's not really clear, but ठीक है, समझ रहा है क्या है. This is a specimen of 2 fetuses seen in close proximity and attached to one another. So the most likely diagnosis is conjoined twins. What can they ask you? How are conjoined twins formed? When division of fertilized ovum occurs after 13 days of fertilization, is more likely to result in conjoined twins. What are the various types of conjoined twins? Right. Thoracophagous, united at chest, thorax. Omphalophagous, fused at abdomen, omphal. Pyophagus, fused at the buttocks. Ischiophagous, fused at the ischium. Craniophagous, fused at the back of the head, piche. And cephalophagous, fused at the head. Remember the acronym TOPIC. So thoracophagous, TOP. Okay, omphalophagous, pyophagus, ischiophagous, craniophagous, and cephalophagous. How will you diagnose conjoined twins? Suspect conjoined twins in USC if the following features are present: inseparable or fused body parts, no change of relative position of both the fetuses, both heads at the same level and plane, twins facing each other, thoracophagous, omphalophagous, thorax in close approximation, thoracophagous. What will be your plan of management if conjoined twins are diagnosed? Termination of pregnancy is offered when the shared organs are vital and single, such as heart and brain. So, conjoined twins are delivered by cesarean section, as allowing for normal delivery can lead to obstructed labor. Feasibility of separation of twins after birth should be discussed with the specialists. Surgical separation may be possible in conjoined twins with no major malformations, such as presence of only fusion of bones. So, only if they are fused at the bones, so surgical separation can be possible. So we are done with all the specimens they can ask you in obstetrics. This was part 1 of the specimen series in OBGY. Part 2 would be all the specimens they can ask you in gynecology. So all the gynecological specimens. If you found this video helpful, please let me know in the comments below, and do come back for part 2. Thank you so much for watching. Bye.